after 35 is nil. So the age more than 35 itself. So if you take 2 years to get pregnant, you are 38, 39 to become pregnant. Is the lady ready? Are there no other medical disorders for her to carry through the pregnancy? Is going to be another question. So age, I think the cutoff should be 35, even though contraindication says 40, but after 35 the results are not good. And in the whole slide, please watch out, more than 3 to 4 factors cannot be determined pre-surgically. You induce the patient, give her the risk of anesthesia, put in a laparoscopy, find out you can't do laparoscopy or recanalization for her because you do not know what the distal end is, you do not know what your end result is going to be, you do not know what actual has gone inside her. It is not only the surgical technique which matters, a lot of other factors including PID, post-op recovery, all those matters when you consider the tubes. So, most of the contraindications is not predictable in tubal recanalization. In IVF, absolutely no contraindications. If a woman is eligible to become pregnant, she is eligible to undergo IVF. If pregnancy is not contraindicated, there is no contraindication for IVF. Delivery. Now the next one we are going to say, oh yeah, you do IVF and we are going to deliver everybody by cesarean section. Please, there also we are moving ahead. There are a lot of newer studies that are saying you can deliver people by normal delivery. By another 2-3 years, there will be pretty number of normal deliveries happening post IVF. We are trying normal deliveries in our centers. Unless it's a multiple pregnancies, singleton with low risk factors, we do try. Cesarean rates are high in IVF. It is not only because of IVF, it is at the age and other medical disorders which comes along with the procedures. When I do it at 38, 39, the chances of PIH and everything goes up. So the cesarean rates are higher because of late IVF. It is not because we are doing it at early. If we have started doing IVF early, I am sure we can deliver everybody by normal vaginal deliveries. So please don't tell me delivery is why we need to do tubal recanalization results. Okay, the best results of tubal recanalization is seen around 2 years. IVF is instantaneous. Next 3 months, 2 months, you know the results at the 30th day. You can give them a result very short term. There's no long waiting periods. Blooming number of IVF centers are there. Great people who are trained in IVFs are there. Anybody can do IVF. To quote the US CREST study, they said, of all the people who inquired about tubal recanalization, who wanted to do tubal recanalization, only 1% went ahead and did it. 1%. So the scenario is supposed to be worse in developing countries. So you're going to make a patient who's already depressed, not having lost a child or not having a child, to wait for more time to make her more miserable. Is that what we are looking at? Sorry, this slide is a little, cramped. The overall, I'm comparing the pregnancy rates, 30%, 50%, age, obviously poor results after 35 in tubal surgery, we have age no bar. We are talking about pregnancy rate per patient in tubal surgery. We are talking about pregnancy rate per cycle in tubal surgery, in IVF. One time, it is invasive. This has got a great success rate. We need the ideal patient to get, I need to search for the ideal patient who's young, great tubes, no other factors, no male infertility, and I need to select the perfect patient and the perfect doctor. The doctor who has got the patient's perseverance and can sweat it all in the theatre and counsel the patient to the non-stop questions possible. There, it's a single cycle. Last but least, we say it is natural, it is artificial. What is natural, what is artificial? As far as says vaginal delivery, cesarean delivery. Nothing is natural, nothing is artificial. You have a child, it is all, producing a human is supposed to be natural. So, IVF-ET, better choice. Dominant role in any type of tubal factors. We have blooming number of IVF centers. The success is per cycle, less surgically invasive. There is decreasing trend of complications. We need to look at age, ovarian reserve, prior fertility, number of children needed, site and extent of damage, presence of other infertility. This is all for tubal recanalization, not for IVF. We get 8 embryos, store them, transfer one, get them pregnant. Want to have a child in 3 years? Go ahead, you have embryos stored. What is stopping you from having 2 children, 3 children with the same embryos which has been stored? I don't think there's any contraindications. And sorry. The patient, last but one, patient preference, religious beliefs, cost, insurance reimbursement should also be considered when we are looking at this. Last but not the least, please do not compare test match with a T20, and you know which one is T20. Thank you so much. Thank you for giving me an opportunity to be here. Thank you.
What about that case?
Now, we have Dr. Jyoti Sundaram who has talked about the percentage of cesarean sterilizations, and especially after tsunami she has done a huge work on tubal recanalization. She has talked about the limitation at the age is for 35 years, length of the tube, and the pregnancy rate she has quoted between 40 to 85% depending on the procedure date, and she has said the contraindications, whatever, both of them have accepted the contraindications for the IVF promotion versus the ART procedure. Now, Madam, Gayatri has come out saying that the cost is less with IVF. I'll give you the thing and then you'll answer. Then, complications is, she has said, no voyages, whereas in tubal surgery you can have complication. And she has compared the ectopic, that is where you stand little less. You said 18% and she said 1%. And the high contraindication she has also accepted. And she said, absolutely for IVF there is no contraindication at all, you can do it for anyone, everyone. And delivery by cesarean is only for late IVF, she has said. And ideal patient is required for your procedure. So answer Gayatri in all these things.
Gayatri.
No, 1 minute, 1 minute.
Yes.
1 minute.
She said the IVF centers are blooming. I accept. But our patients, we are from a developing country. Our patients are not blooming and they are not having enough money to come to these blooming IVF centers. So they are poor people. They come to the government hospitals to us only. So
she said the cost is 12,000 in IVF and she said 18,000 with tubal recanalization. Please.
all
All of you accept what she said?
No, definitely no.
Whoever accepted raise hand. IVF is less costly than tubal recanalization. Whoever accepts.
A surgeon can charge one.
No, we are not talking about IVF to delivery. We are not talking about only the surgery or the procedure.
I talk about from the procedure to delivery. 12,000 for IVF. IVF is
Dollars.
IVF is 12,000 rupees. Tubal recanalization is 16,000 rupees. So the point accept padla madam. Adala baaki point solunga madam. Clinical pregnancy rate you said 40 to 85.
Yes.
And she says 57% in IVF.
In selected patients.
So the selected is about another bomb. Otherwise, tubal recanalization as an average 40%.
40%.
So IVF is little better, 55%. Accepted? So cost not accepted, but the percentage of success accepted. Then she talks about absolutely no contraindication for IVF. For your patient, there is contraindication. What is your opinion?
It's not like that, madam. There are in few patients.
There are contraindications. How do you say that IVF there is no contraindication?
If a patient can become pregnant, you go ahead with IVF. If a patient can become pregnant. So my contraindication, if you are contraindicated for pregnancy, don't do IVF.
So her contraindication is based on the chances of her pregnancy and this thing. So it is not for the IVF. So for IVF she says there is no contraindication. But for you, you have a limited contraindication. So in the first factor, it was not accepted. In the second, it is accepted that IVF gives better results. In the third, contraindication for tubal recanalization, yes, it is there. So these 3 points are acceptable. So except the cost involved and the percentage of success, if supposing whether it is in the government hospital or in private hospital where the facility is available or not, when it comes to the procedure, tubal factor gives less success than IVF. Accept, madam? Yes. Jyoti Sundaram madam herself has accepted that, yes, she said 60 days and you will have to wait for 6 months. So,
course, yes.
in the present scenario, if the patient says for her we are counseling is, there is a slight age of betterment with IVF, less with tubal recanalization, but as she said very clearly, the expertise is very much required. IVF can be done by all people. Only the embryologist has to know better things. Clinician did not know. Am I right? Injection மட்டும் போட்டா போறோம். Embryologist தான் வேணும். So with a good embryologist, everybody can do IVF, but for surgery, only people like Jyoti Sundaram who have done IVF canalization in camps can do it. So there are far tubal recanalization, far IVF also. With all your acceptance and the cost and the success, shall we say IVF is little better than tubal recanalization?
Yes.
Accept?
Ma'am has accepted. I think that's done. Jyoti ma'am has accepted.
Evidence based we have to accept. Accept? Chakravarti sir? Really?
Sir has given so many success to recanalization.
That's what I said.
Everyone is assistant.
The great surgeon, ma'am. First slide like all vindachu, ma'am. The great surgeons, we are not including great surgeons. We are including normal.
The expertise of the surgeon is what is important.
Ideal patient, great surgeon.
From our seniors, ma'am.
Great surgeon, ideal patient.
From my teacher.
Final part.
It's not final command. As Madam has said, in government system, because I served for 26 years, and at the time, that's why my English were there, was successful. Legalization, very good. Fortunately, I was trained by one Dr. Banker from Aval. Medically, she taught me for 15 days, starting from gloves, then wraps, then tubes, then vasectomy tubes, all these things, 15 days. He gave me the lab 24 hours time. So, as she said, we are getting proper time. But in the government sector, I vote for it. Because
So we vote for both.
No.
This side and that side.
I cannot vote because there is no government sector where I did this. Only they will stop.
Government has accepted IVF centers in Madurai and Chennai.
Yes, just started. It take a long time. I think 87 in government maternity hospital, Egmore, we started. That's all.
Dr. Mohan Sundari at Deepak Medical College.
Speaking decision. IVF center started in MH 87 and I just finished it. But it's not started. Went on there. So they started 87, I think we will vote for them. Unfortunately, it not started. Now we are going to start.
87, myself and Vijayalakshmi were the assistants in the.
Thank you very much for this, thing. We hand over the stage to Dr. Umara, the next speaker. Thank you very much, Gayatri and Dr. and the same Jyoti for the wonderful discussion.
Senior consultant in Hindu Mission Hospital, DGO at Savai Mansingh Medical College, Rajasthan. She had her MBBS in Savai Mansingh Medical College, Rajasthan, member of COX. And I welcome Dr. Seema Gautam ma'am. And I invite Dr. Victoria ma'am for chairing the next session. Who had a field of specialization in high-risk pregnancy and reproductive medicine, received the Best Doctor Award 2016 by IMA Tamra, was chairman of Women Doctors Wing in IMA Kanjipuram for the past 2 years and got National Award for the Best Branch of Women's Activity, past president of IMA Kanjipuram, received Best Doctor Award for Community Services.
A very good afternoon to one and all present here. This is Dr. Roshni Nityapriya from SRMC, Porur. I'm first year OBG postgraduate. I will be presenting on the seemingly substantial National Health and Family Welfare Program, Anemia Mukt Bharat. Our nation is in the cusp of writing history in terms of its socio-economic development. However, anemia remains a major public health issue across the country in terms of its prevalence, irrespective of the age, gender, and geography. It's high time that we intensify the tackle against anemia to promote a better health outcome. With this, I start my capsule. The Anemia Mukt Bharat program was launched in 2018 by the Ministry of Health and Family Welfare, Government of India, to accelerate the decline of anemia in various age groups. Here is a snapshot of the prevalence trend as per National Family Health Survey 2, 3 and 4. The most distressed groups would be 58% of the children between 6 to 59 months of age, as well as the breastfeeding mothers. Let's throw ourselves way back to the milestones developed in terms of control of anemia in India. In 1970, this program was first launched as National Nutritional Anemia Prophylaxis Program with distribution of 60 mg of iron folic acid for pregnant women as well as for women of reproductive age group for a period of 100 days. In 1991, it was switched, the dosage of the iron was switched from 60 mg to 100 mg, and it was later renamed as National Nutritional Anemia Control Program. In 2007, there was an inclusion criteria of 5 to 10 years age group. In 2013, there was an introduction for weekly and bi-weekly supplementation as per WIPS program. In 2018, it was still intensified and was called as the Intensified National Iron Plus Initiative Program with the supplementation of 60 mg of iron folic acid for a period of 180 days for pregnant, lactating as well as for women of reproductive age group. It came with a strategy of 6x6x6, thus breaking the intergenerational cycle of anemia. Talking about the INIPI program, which complies the targets of Poshan Abhiyan, which is nothing but PM's overarching holistic scheme for nourishment, or Pradhan Mantri Poshan Shakti Nirman Abhiyan. Along with the National Nutrition Strategy set by Niti Aayog, this strategy has been designed to reduce the prevalence of anemia by 3 percentage points per year. Here's a strategy pyramid which has 6 beneficiaries, 6 interventions, as well as 6 institutional mechanisms, thus wrapping around nearly 50% of the country's population. The partner institutes of this AMD strategy include Institute of Economic Growth in New Delhi, which is an autonomous multidisciplinary research center in anemia control, and the offshoots of All India Institute of Medical Sciences, New Delhi, which is National Center of Excellence in Advanced Research on Anemia Control and Diet. Last but not the least, the Tarak Hub, which hosts institutional programs in promoting anemia control. These are the beneficiary-wise targets as per AMV Schedule 2022. The 6 beneficiaries would be children between 6 to 59 months of age and 5 to 10 years old children, pregnant and lactating women, women of reproductive age group 20 to 49 years of age. The 6 interventions will be prophylactic iron folic acid supplementation, following which I will be dealing with the future slides. For 6 to 59 months of age, 1 ml of iron folic acid syrup bi-weekly, with each ml containing 20 mg of elemental iron and 100 micrograms of folic acid will be given. For 5 to 10 years old children, 1 sugar-coated pink-colored iron folic acid tablet containing 45 mg of elemental iron with 400 micrograms of folic acid is given weekly. For adolescent girls and boys between 10 to 19 years, 1 sugar-coated blue-colored iron folic acid tablet with 60 mg elemental iron and 500 micrograms of folic acid is being given. For women of reproductive age group, 1 sugar-coated red-colored iron folic acid tablet containing 60 mg of elemental iron with 500 micrograms of folic acid is being given. All the women in the reproductive age group in the pre-conception period up to the first trimester of the pregnancy are advised to have 400 micrograms of folic acid tablets daily. For pregnant and lactating women, 1 iron folic acid tablet per day starting from the second trimester to be continued for 180 days. Contraindications for iron folic acid prophylaxis include first onset of the pregnancy. Although iron is a weak mutant, it is a powerful catalyst for formation of hydroxyl radicals, thus curtailing the iron absorption in the mothers. Any history of anaphylaxis or adverse drug reactions, patients with evidence of iron overload, known cases of thalassemia, sickle cell anemia, and hemolytic anemia. For severe acute malnutrition children, iron folic acid supplementation as per SAM management protocol for catch-up growth can be given. Indications for parenteral iron include non-compliance in the postpartum period and if there is any requirement for rapid iron replenishment. Deworming regime is the second intervention. Biannually, all the 5 beneficiaries except for the pregnant women will be dewormed with 1 mg 1 tablet 400 mg albendazole for pregnant women, preferably given after the first trimester. Intensified year-round behavior change and communication program includes focusing on social mobilization and behavioral changes. This focuses more on appropriate infant and young child feeding, which emphasizes more on early initiation of breastfeeding, following birth, within 1 hour of birth, and exclusive breastfeeding, as well as the initiation of complementary feeding at 6 months of age, as well as about the diet diversification and the practice of delayed cord clamping in all the health facilities. These are the various communication aids in order to encourage the self-efficacy and to increase the motivation for anemia control and prevention among the children. Various booklets and the radio programs are being telecasted for school children. Test and treat intervention for anemia among pregnant women and adolescents include 2 groups. One is pregnant women and the other one is school-going children. For pregnant women, they screen with digital hemoglobinometers at every antenatal visit. And for school-going children, annually the screening is being done by Rashtriya Bal Swasthya Karyakram team by using the digital hemoglobinometers. These are the various steps of drawing blood for digital estimation. This slide holds the importance of the cuvette or micro cuvette holder, which is a beautiful innovation in the digital hemoglobinometer, which has an advantage of drawing 10 microliters of blood at one go. Provision of iron folic acid fortified foods. The government of India has mandated the use of fortified salt, wheat, flour and oil in foods served under ICDS and midday meal scheme. So this is also being mandated in all the health facility based programs where food is being provided to supply with fortified wheat and rice with iron and folic acid and vitamin B12 and double fortified salt as per FSSAI standards. Intensifying the awareness and screening and treatment of non-nutritional causes of anemia include focusing more on usage of long-lasting insecticidal nets as well as the indoor residual sprays for preventing malaria and on the safe and hygienic drinking water as well as diet correction for calcium, magnesium and vitamin C deficiency for fluorosis. The 6 institutional mechanisms include intra-ministerial coordination, National Anemia Mukt Bharat Unit, National Center of Excellence and Advanced Research on Anemia Control, convergence with other ministries, strengthening supply chain and logistics, Anemia Mukt Bharat dashboard and digital portal, the one-stop shop for anemia. Here's that dashboard and digital portal for EMB, which is a one-stop shop for anemia. You get it online. This is a one-stop shop to purchase all the communication and resource materials if you are volunteering, or you can also serve the survey data and also about the AMB targets per year as per the National Family Health Survey. And there's an Anemia Mukt Bharat application available in Android as well as Apple Play Store where you can visualize the tables and graphs to see which state has stopped and which state is still lagging down in anemia control. These are the newer things which are covered. There's also a special focus for newly wed women between 20 to 24 years of age. So let's all put our hands together in increasing the motivation as well as the self-efficacy for preventing anemia control and creating an anemia-free India. Thank you, Cox. Thank you to everybody for counting me in and patient listening. Thank you.
Thank you, Dr. Rashmi. It was a nice presentation. And actually, you covered iron deficiency anemia. You also told about the anemia in boys and non-nutritional causes of anemia. That was fluorosis and hemoglobinopathies that was stressed upon. That was a nice presentation. Thank you.
Thank you, Roshni Nityapriya. I now request Dr. Hepzibah Kirubamani Madam to deliver a talk on risk assessment in midlife.